Thank you so much for the invitation. I'm very happy to be here to speak about my favorite topic, delirium. I think about delirium every day, many times a day. I've done that since 2005, and even actually before that as well, because I started in 2002 working as a nursing assistant in a nursing home, and so lots of delirium at that time, but I didn't understand that it was delirium I saw. In my PhD, I looked at delirium in hip fracture patients, so I've been lots of hours in the orthopedic unit as well. But I'm in the geriatric medicine part of the hospitals. And before we go on speaking about delirium, I want to ask you, geriatric medicine, what is a geriatric patient? Who is she or he? When you think about that, you might think, okay, that's an old person. And I agree that age is perhaps the main risk factor of being a geriatric patient. But you all know a fit, elderly, 80-year-old person, a 75-year-old person, perhaps still working. Is she or he a geriatric patient? You are shaking your head? No? Why not? 75, 8 years old? What characterizes a geriatric patient? Do they have many diseases? Yes. Do they use many medications? Yes. Do they need help in their daily activities, daily life? Yes. Is age among those factors? No. Is age a risk factor of having those? Yes. But you see that you will meet 85-year-olds that are perhaps not geriatric patients, and you will also meet 60-year-olds that are geriatric patients, right? Yeah. And in geriatric medicine, we know, of course, like you also know, that we age differently. And you know, some are 8-year-old, but they look like they are 20 years old younger, right? So their chronological age and their biological age doesn't always correspond. And in geriatric medicine, we speak very much about frailty. And this is perhaps a term that you also know about, because we know that the degree of frailty is something that corresponds much better with biological age than your chronological age. But who is a frail patient? Frailty is quite hard to define. It's about that you have a lack of reserve capacity. Your reserve capacity is not as good as it was. The easiest way to explain what frailty is to say it's the opposite of being fit. It's the opposite of being robust. To use two examples, this is a frail, elderly nursing home patient. Nursing home patients, the most frail group of patients we have in our society. This woman, this is an old picture, but she is the champion in water skiing, Lucille Borgen. It's not a fake photo, it's quite real. And she was a champion until the year of 94, I think. If these two, I don't know these two people's health, but I tell you that, okay, we decide that this is a frail woman, this is a fit elderly woman. Their age is the same, their chronological age is the same. If these two women get their urinary tract infection, will they have the same symptoms? Shaking your heads again. For those of you who have been working in a nursing home some time, or have old, frail patients in your daily care, if this elderly, frail woman gets a urinary tract infection, do you necessarily understand that it is that is where the problem is? Does she get pain when she's urinating? She has to run to the toilet all the time. Is that the classical symptoms in old patients in nursing homes? No. What do you see? How do they walk or stand on their legs? Poorly, right? They start to fall. What about their head? Do they think clear and be alert and they get confused? Stop eating and drinking, get dehydrated. They are not able to do their activities as normal. And that is with frail patients, when they get acute illnesses, they lose function. And that is also often the most visible sign of the acute illness is the function loss. And sometimes the symptoms from where the problem actually is absent. So you can meet patients that have heart attack without chest pain, severe infection without fever, urinary tract infection without having this pain when they urinate, and so on. You agree? Yes. But this fit elderly woman, do you think that she will have pain when she urinates if she gets a urinary tract infection? Yeah, I think so. So if you are fit, you get much more, it's much easier to diagnose them because they get symptoms from where the problem is. But in frail patients, they get much more vague symptoms. And we call this the giants of, it's the giants of geriatrics. So acute illnesses in frail older patients often presents with delirium, falls, immobility, incontinence, dehydration because they stop eating and drinking, and so on. And I have to say it because you work in orthopaedics, so remember, if you have a patient that has fallen, you always have to ask yourself, and the doctor must ask the patient, why did you fall? What led to the fall? Was it an accident, or was the fall a part of any acute illnesses? Has the patient got a new medication 5 days ago that she shouldn't have, and so on? Always ask about what lies behind this. But it's a little bit unfair, because if the fit elderly patient gets like a minor illness like a urinary tract infection, she gets some loss of function, but when she gets treatment, she recovers quite well, and she also comes back to the same level of function that she had before the acute illness. I told you that frail patients has loss in reserve capacity, and this becomes very visible when they get acute ill, because this frail patient, when she gets the same acute illness as this fit person, she got a much worse loss in physical function. Although she gets the right treatment, she uses much more time to recover, and we often see that they don't recover completely. So in nursing homes patients, for instance, we see that they get an acute infection, get very ill and lost function, they recover slowly, but not completely. And later a new acute, and you see that the function is falling stepwise. And it's just because she doesn't have the reserve capacity to recover back. To go through some of my patient stories, I could tell you hundreds of examples of this, but I take this woman. She is 84 years old. She has a high blood pressure, some heart disease. She also has had cognitive impairment for the last 3 years. Patients with dementia, how many do you think are diagnosed? How many of patients with dementia have the diagnosis of dementia? Of course, this will be different from countries to countries, but in Norway, where I come from, it's like we believe that perhaps 20 to 30% of patients with dementia have the diagnosis of dementia. So you mustn't look to the medical record if you wonder if your patient has dementia. You have to ask the caregivers, because the probability to find it in the medical record, that diagnosis, it's more, the probability is higher that it's not there, although the patient suffers from dementia. But this woman functions quite well, although she has her problems, but in her house she is able to dress herself, she can eat and make small meals at her home every day. So the home care nursing is only in her house every morning to see that she is taking her medications. But then it was one day that a healthcare worker finds Mrs. Olsen asleep at her couch. She's drowsy and makes only brief eye contact. She needs support when walking to the bathroom, and she's not able to dress herself. She seems confused and doesn't take instructions. And the same healthcare worker had been in her house the day before, and then she was just as normal. So this is an acute change. Age, high age. Can that lead to acute changes in function? Can you get old from one day to another? No? Dementia, can that lead to acute loss in function from one day to another? Dementia that does suddenly lead to steep loss in function from one day to another? No, no. But how often do you think that I hear that, but she's old, you know, she has a dementia, it's not that strange that she now needs much more help? How often do you think that age and dementia are explained to me for the reason behind such loss of function? Right? Something must have happened. Because the biggest mistake you can do with such a patient is to say, now Mrs. Olsen needs tender love and care. If we need to go to her house 4 times a day and help her to eat and drink and dress and so on, right? She needs tender love and care as well. But what we also need is to find out what has happened. Something what has happened with Mrs. Olsen, what has led to this acute change. The healthcare worker did everything right here. She took the patients to the woman to her doctor, and she was admitted to hospital, but she died 2 days after of a severe infection. And these were the main symptoms of this very serious infection. So then we go on to delirium, because delirium is the confusion is often the most prominent symptoms of such acute changes. If we go to the textbooks, the medical textbooks, we find that delirium is an acute change in mental status, inattention, cognitive disturbance, and altered level of consciousness, fluctuating course. Delirium is a symptom of an underlying cause and is per definition reversible. I hate such lists, because if you tomorrow is going to tell your colleague, okay, can you tell me what is a delirium? You're not able to reproduce such lists, right? So I think it's much better to go into your daily life. We go to the orthopedic unit. And at the orthopedic department, we find 2 women. First, an 82-year-old woman, she had a hip fracture 2 days ago. Last night, she was agitated, hallucinated, she removed her urinary catheter and climbed out of bed. She got haloperidol, diazepam, levopromazine before she fell asleep. This is a doctor that doesn't know what to do, right? Yeah. And this patient is much more recognizable. You can recognize this patient more than that list, right? Every one of you have seen such a patient. Agree? In the other bed, 84-year-old woman as well. She had a hip fracture 2 days ago. She is lying in bed, seems drowsy, few spontaneous movement, is disorientated. No problem for us who are working with her. Both of these women have delirium, because they illustrate the hyperactive delirium that the first woman had and the hypoactive delirium that the second woman had. But I told you earlier that delirium fluctuates. So actually this might be the same patients, because you also have the mixed delirium. And the typical thing is that in the night you meet agitated woman. We are few at work, and it's, you know, that you go home that morning and it feels like, oh, I'm way too bad paid, right? Because I have been working with this patient for so many years. I know how stressful it is to handle patients with hyperactive delirium. And then it's quite typical that when more people come at work in the morning, when the doctor is going to see the patient, then that is the patient in the hypoactive delirium that you meet, right? It's quite typical. But delirium fluctuates. Regarding hallucinations, about 50% of patients with delirium have hallucinations. And so it doesn't mean that everyone, you don't have to have hallucinations to be in a delirium. But remember, they are often very frightening, those things that the patients experience. And I will speak a little bit about how you should treat and how you should cooperate with patients with delirium, but remember one thing. Try to remember how scared these patients are. They don't tell you that they are scared, they show agitation, but they are so scared, they are fighting for their lives because they think that you are going to kill them, that you are going to hurt them, and so on. So try to create safe environments. This gets so much easier for us as healthcare workers to cooperate with these patients if we have safety, create a safe environment for the patient, if we think about that all the time. But remember, delirium is just a symptom of something else. Delirium has a cause. It is a manifestation of something acute that has happened. And it's not only delirium, but also patients with dementia remember that when they change their behavior, they communicate, you know? A patient with a change in behavior is communication. So you have to think that a patient that is behaving very strangely, he tries to communicate something to me, but he's not able to tell this by words. The patients that has the highest risk of developing delirium is old patients and patients with a vulnerable brain, patients with dementia. So high age and dementia are the main risk factors for delirium. But we can all have a delirium. I can get a delirium. If we think about predisposing factors, risk factors for delirium, I'm quite young, I do not have any diseases that I know about. I have a low vulnerability to get a delirium. But also I can get a delirium if something very serious happens to me. Severe infection, sepsis, multi-organ failure, so on. I have to go to the ICU unit, you know, car accident, so on. In the ICU unit, almost 80% of the patients in the ICU has a delirium. And it's not because they are very old and frail, it's because they are so sick. But the more risk factors you have for delirium, the higher degree of frailty. If you are old, you have a dementia, you have many chronic diseases, you have vision impairment, hearing impairment, you are thin, then you have a high vulnerability. And in these patients, a delirium can be provoked by a much milder illness. And that's why nursing home patients, for instance, can get a delirium by a urinary tract infection that would never provoke a delirium in you, because you are much more robust. So remember, if you have a patient that is an old, fit lady who gets a delirium, then you must think this is something serious, right? Because she is quite robust. But in old, frail patients, then delirium can be triggered by one sleeping medication, a mild infection, and so on. But how common is delirium? If we go to the nearby hospital, we will find that about 10 to 15% of all hospitalized patients has a delirium. If you only examine patients that are old, we'll find that more than 20% has a delirium. In hip fracture patients, most studies found that around 50% has a delirium. Is there something about you that get this high degree of delirium in the orthopedic unit? I clicked 2 slides back. High hip fracture patients, are they a fit and robust group of patients from before? Do they have many chronic diseases? Yes. Do many of them suffer from dementia? Yes. Do they have a high mean age? Yes. More than 80 years old, right? And one other thing is that, you know, frailty. An easy way to measure frailty is to see how fast you are walking, you know, gait speed. How fast are you walking? It's a very good indicator on your frailty. And if you are a fast walker, then you are probably fit. If you fell, what do you break? You break your arm, right? If you are a frail person, you walk slowly. And if you then fell, what do you break? Your hip, right? Do you see? Patients with hip fracture are often frail. And then you have a group with a high degree of frailty. A hip fracture, is that a mild, small thing? No, it's a big trauma, right? It's painful, they had to go to the hospital, operation, and so on, you know? So then you have a group of patients that are frail and are exposed to a severe insult. And that's why 50% get a delirium. You may not relate to these numbers. Say, okay, I don't know what you do in Norway, but this is not correspond to what I see in my daily practice. This is a study from Ireland. It's a hospital with 400 beds where they examined all patients for delirium. And they found that 19.6% had a delirium of the patients. But this is not the important thing. The important thing about this study is, among patients with delirium, in only 43.6% of the cases, symptoms of delirium or diagnosis of delirium were found in medical record. So delirium and symptoms of delirium is not well documented. And for instance, this drowsy elderly woman who is not a problem for me when I'm at work, it's easy to not document. You can just write that she's tired and after the operations, for instance, and you don't examine her acute cognitive failure. So delirium is overlooked. We know that delirium is not detected in about half of patients with delirium. 3 out of 4 patients with hypoactive delirium in the emergency room is not detected by the doctor in the emergency department. And we also know that every second day in active delirium is associated with an increased mortality of 11%, what the study found. It's not that you die of a delirium, but it's just that the delirium is an indicator, and active delirium is an indicator that you do not have full control over the acute events. You know, so the infection is not well treated, the pulmonary embolism has not been discovered, and so on. So how can you detect delirium in your daily work? Rule of thumbs I like easy answers. The best thing you can do is to ask the caregivers or someone else that know the patient, is your mother as she is normal? Is she more confused than normal? Ask that only, if you ask that one question to someone who really knows the patient, then you will find 80% of all delirium, only by asking that single question. And it's actually called single question in delirium. Is the patient more confused than normal? Because if you don't know the patient from before, and when you're working in hospitals, it's impossible to know the patient before unless you have had the patient every day for the last week, and today she is much more confused than what she was yesterday. But in other ways, it's impossible to know who your patients are when it comes to cognitive functioning. But it's so often that I go to the hospital and I ask, okay, do you think that she is a delirium in that patient? No. Well, she's 86 years old. I think that she's dementia. It's a dementia that I think that. And I say, okay, but have you spoken to the caregivers or someone else that know the patients? No. And then I can tell, because you know that woman, she drove her car last week. She don't have any help in activities of daily living. But so often I'm told that when a patient has a delirium, they think it's dementia because the patient has a high age. So we have to ask not yourself, but someone who knows the patient from before. Well, that was a single question in delirium, but there are other instruments as well. The most famous instrument when it comes to delirium screening is called Confusion Assessment Method, CAM, perhaps known for many of you. It's developed in 1990 by Sharon Inouye. She's called the Queen of Delirium, professor at Harvard. I like that title. I'm a little bit, I would like to have it myself. No, I'm just joking. It consists of 5 questions. Number 1, is there evidence of an acute change in mental status from the patient's baseline? Yes or no? Number 2, is it signs of fluctuations? No, because delirium tends to fluctuate. So what you saw when you were at the patient at 8 o'clock in the morning, you go in 1 hour after, the situation might be changed a lot. In attention deficits, it's a cornerstone in delirium diagnostic because patients with delirium, they are not able to keep attention, able to focus on a task. I will give you a test of attention now, because what is attention? It's to be able to concentrate. And by doing this task, you will understand what it is. Because now, you shall all say the months of the year backwards, together with me. December, November, October, September. You understand what attention is now? You have to concentrate, right? It's to keep your focus. That is attention. And patients with delirium has attention deficits. And that is why it's so hard also to work with this patient, because they don't take instructions. When you help them to dress them or they are going to eat, they lose their concentration among that task. So they are not able to dress themselves. For the physiotherapist, it's quite challenging because a rehabilitation of a patient with delirium, a patient that does not take instructions, is very challenging. But it's a cornerstone of delirium symptoms. Patients with delirium also have disorganized thinking. They are not able to think logical. If you tell them, okay, today is Friday, what was the day yesterday? They are not able to think that it was Thursday yesterday. And then it's also this altered level of consciousness. You know, if they are alert and normal, that they get across here. But if they get across in this gray box, hyper-alert, like a hyperactive delirium, or drowsy, difficult to arouse, this is signs of hypoactive delirium. So if the patient gets across at least a yes, a 2 yes in box 1, and at least 1 yes in box 2, then delirium is, the probability of a delirium is more than 90%. And you can use these questions also when you write about your patient in the medical record. The patients are acute mentally changed from yesterday. He has an inattention, the symptoms are fluctuating, and he seems more drowsy than what he normally does. Then it's like 2 lines, and you have done a full delirium diagnostics, right? And that's much better medical record than just the right patient is a little bit confused, because that doesn't tell me anything. CAM is a good instrument if you love delirium, like I do, and you work lots with delirium. But if you don't work with delirium and you think about yourself, I will never be that interested in delirium, then you should perhaps choose another tool. A new tool called the 4AT. You can find it on it's free available at the 4at.com, and it's also translated to many different languages. It's quite new, but the good thing about the 4AT is that the questions are much more specific than in the CAM. Because here on attention, you actually are going to do a test of attention. So if you use the CAM or the 4AT, I don't care. But choose one of them. Number 1, alertness. Is the patient drowsy, or is there a sign of hyperactivity, agitation? Then you do a short cognitive test, ask the patient what is your age, when are you born, where are you now, and what is the current year. And then it's a tension test, and then is there signs of acute change or fluctuation, yes or no. And it's much better described under here, so it's easier to use the 4AT if you're not very into delirium diagnostics. When it comes to attention tests, you did now the months backwards, but that is a quite hard test. So if you have, for instance, a patient with known dementia, you should choose a easier test of attention. For instance, ask them to say the days of the week backwards, Sunday, Saturday, Friday, Thursday, or count from 20 to 0, 20, 19, 18. Or you can ask them to hold your hand and say, and then you say to the patient, now I'm going to say a number of letters, and every time I say the letter A, you're going to press by hand. B, A, P, Q, A. So then the patient has to focus, and every time you say A, they're going to press your hand. So then you can also use it if the patient has some problems with speaking and so on. When it comes to this question regarding drowsiness or agitation, there is an instrument that we have borrowed from intensive care, and that's the Richmond Agitation Sedation Scale, the RUS scale, perhaps known for some of you. Because if you have a RUS score of 0, then you're alert and calm, like you. Perhaps you start to get a little drowsy, I don't know, then you are a -1, right? Because then you'll see here that you get less eye contact. And remember that patients with delirium give very poor eye contact. They are wandering their eyes. But also when it comes to agitation, you see that, for instance here, restless, anxious, or apprehensive, but movements are not aggressive or vigorous. You see patients with delirium, they don't need to be crazy to have a delirium or be violent. You know, they can also be this, you know, this lying like this in the bed. You've seen all these movements, right? Or their foot are going up and down. That restlessness, it's signs of hyperactive delirium. So then you have to think, okay, what is this patient telling me? Does he have pain? Is he thirsty? Is he scared? Is he obstipated? Has he emptied his urinary bladder? And so on. You have to start to think, what is the patient communicating to me? Because something is not okay in his body right now. A typical example, 3 a.m. in the middle of the night, nurse calls. The patient is crazy, can I give him haloperidol? Right? This is a true picture of a patient in hyperactive delirium. When I get these questions, I do not ask, but I think, if they don't present me with another problem like this, I always think by myself, haloperidol, which is an antipsychotic for you, those of you who don't know. Does that help for pneumonia, severe infections, chest pain? Does haloperidol help for if you are not able to empty your bladder? No? What does haloperidol? It's only the symptoms of delirium that haloperidol can mask. So remember, haloperidol never treats delirium, okay? It only lowers the symptoms, because haloperidol is not helping for the underlying cause. After we have had delirium training, I get questions like this. Maria, since midnight, the patient has become more restless. He's now a RUS +2 compared to RUS 0 at 8 p.m. He has no fever, but his infection parameters are increasing from admission 2 days ago. Can you come and take a look at him? When I get a question like this, or if you ask this question to a doctor who is not that interested in delirium, a doctor that is not very interested in delirium might say, yes, go on, give him haloperidol. But if you ask this question, then it's much higher probability that the patient will get the right treatment that night, not only lowering the symptoms on his delirium. Because delirium is just telling us that something is wrong, but what is wrong, it's not telling us. Delirium can be prevented, and I was very happy to hear that lecture you had just before me by CD, because actually that is delirium prevention. The first paper on showing delirium prevention is 20 years old, also by Sharon in Norway. And in this paper, they found that they could prevent delirium in 30% of the cases. What did they do? You know, for your hip fracture patients, for instance, most of them will come to the hospital without a delirium. And in those patients, you can do things that can prevent the patients from getting delirious. In many medical patients, they have a delirium as a part of their acute symptoms, like Mrs. Olsen that I showed you earlier today. In her case, delirium can't be prevented because delirium is already present. But in patients with high risk of delirium, like hip fracture patient, you can do something to prevent delirium. And in this patient, 30% reduction. What did they do? Well, this is very small letters, so you don't need to read them. But it's just to show you that it's actually true what I'm saying. It's not the advanced medical treatment, this, because what they did the patient less frail. In cognitive impaired patients, they had a cognitive stimulation protocol. They had a clock and calendar in the rooms. They reorientated the patient all the time, spoke with short sentences. They let the patients sleep during the night, no procedures in the middle of the night, no noisy corridor patients and so on, and dark in the night, light in daytime. The patient was early mobilized, right? Had an early mobilization protocol. Visual impairment and hearing impairment was a focus on, and also a dehydration protocol. So it's actually this framework, and it's good standard care. But I know that when I come from work, not all my patients are well hydrated. Not all are mobilized. These are quite hard to implement, but we know that they are very effective. And there is no pharmacological prevention. It's not that we can give all patients with hip fracture, for instance, a drug when they are in the emergency room that will help them to not develop a delirium. Your patient has delirium. What should you do? It would take me to give you a good answer on this. I need 2 hours, and I don't have 2 hours. So you will only get one slide. Identify and treat the underlying cause. That is delirium treatment. But I of course know that if you have a patient that has, you suspect that he's not able to empty his bladder, it's not easy to put in that catheter or examine him if he's just crazy and have a RAS +4, right? So in such cases, you of course need to lower his symptoms. But also research show that if you have one nurse that has one-to-one with that patient, the effect of a good behavior towards the patient is actually more effective than antipsychotics to try to keep the patient safe. Is delirium dangerous? That is actually what I'm was asked to tell you about. Because it might be like delirium is like a flu. It's not very fun, but when you have it, but you get well and you get yourself again. Well, unfortunately, it's not so. This meta-analysis from 2010 showed that delirium is associated with increased mortality, increased risk of institutionalization, and increased risk of dementia. Not fun at all. So delirium is associated with poor prognosis. I'm very interested in the brain because I think that the brain is the most important organ that we have. I think that you all agree. This Finnish study from the city Vantaa examined all patients, all inhabitants 85 plus, and they were re-examined for many years. And also cognitive functioning was examined among these patients. And what they saw is that in patients that in this research time, in this study time, developed a delirium, they had a much steeper fall on cognitive function than those that did not develop a delirium. So it seems that delirium can lead to dementia. The delirium is a risk factor for dementia. And also, in this American study of Alzheimer patients followed at a memorial clinic, they saw that patients that got a delirium, then their Alzheimer's disease started to progress more rapidly. Have you seen that? Have you heard caregivers telling that, after that delirium, he never recovered in his brain? He never got back to his cognitive functioning that he had before that delirium. Delirium was the beginning of his dementia. And this made me really curious, because do you think that if we get a delirium, will we get dementia? It is one study from 2012, published in the New England Journal of Medicine, which showed that in intensive care units, young patients, 40 years of age, if they suffered from severe delirium for many weeks, 1 year after, they had a cognitive functioning like mild Alzheimer's disease. But these were patients that were extremely sick and had delirium for a long time. But it's not healthy for a brain to be in a delirium. What I did was that to question this, I examined it for 2 years. I used 3 years on the data collection. Frail, elderly, home-dwelling patients. Home nursing care did I have. And I included my patients when they were in a stable situation. I assessed their cognitive, physical functioning, their nutrition, depression. I assessed everything about these patients. And then I reassessed them every 6 months for 2 years. And in Norway, it's like when a patient with home care nursing is admitted to the hospital, the home care nursing is always alerted. So if any of my patients were admitted to a hospital, I knew I got the message and I could go and see the patient and assess them for delirium. So then I knew who my patients was before delirium, and I could reassess them after and see what is the true impact of a delirium. And what I found was, in patients that developed a delirium, these are not finally published, so please don't take a picture, because then I can only tell it to you, no one else. In patients with no dementia at baseline, in those who got a delirium, the cognitive functioning remained stable through those 2 years. But in those patients that had some kind of cognitive impairment at inclusion, in a stable situation, you see that they had some cognitive decline, and if they got a delirium, they got a steep decline in their cognitive functioning, and they did not recover, you see? So it seems like for a brain that has some problems, if you have started to get some cognitive impairment, then you should not get a delirium, okay? Then you have to avoid it, right? So we are actually back to this slide that I showed you earlier today. In the fit brains, in the fit elderly patients, if they get an acute event, they will lose some function, like having a delirium, but they will recover. But if you are frail, if you have an impairment, then you will lose lots of function, you will recover slowly, and you will not probably recover completely. And it seems like that is the case with delirium as well. So, delirium, remember, it can't be prevented. You can treat it, suspect it, spot it, and stop it. And I know you must not be sad if you have lots of delirium in your unit, because your patients are so frail. So if you have a patient with dementia, severe illness, a hip fracture, you can give that patient as good care as possible, but he is so frail that he will probably react with a delirium, whatever you do. But you should, of course, continue to do all those preventive things, the good standard care, because that is actually lowering the symptoms of delirium. So that is the best thing you can do also for a patient with delirium. Put on their glasses. Tell them what is happening to them. Avoid dehydration. Give them food. Invite the caregivers to create a safe environment for these patients. Okay, thank you.